Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, as always, I'm glad to welcome my co-hosts for this regular podcast, Dr. Dan Lenahan. Dan, welcome.
Thanks, Steve, and glad to be here with you and Arjun, and we're going to have a very interesting conversation about endocarditis. So thank you.
Yeah, welcome. And Arjun, how are things in London? Welcome.
Yeah, all good. Temperature's a little bit warmer, so looking forward to this podcast as well.
Well, great to have both of you as always. And it's a real pleasure for us today to welcome Ihab Hamzeh. Dr. Hamzeh is Associate Professor in the Department of Cardiology at MD Anderson Cancer Center in Houston, Texas. And as Dan mentioned, we'll be discussing some work that he's done on endocarditis in patients with cancer. But before we jump into that, Dr. Hamzeh, I wonder if you could just tell us a little bit about your background professionally and how you developed your interest in cardio-oncology in particular.
Hi, good morning, everyone. My name is Ihab Hamzeh. I've been at MD Anderson for almost 2 years now. Before that, I was at Baylor College of Medicine for about 10 years, where I was, we had some cardio-oncology experience, but it was minor compared to here. And a couple of years ago, I decided that, I'm reaching that age where I need to get something more exciting in my life. And I had the opportunity to come and join MD Anderson. And then it was rejuvenating to learn about cardio-oncology. So this is how I ended up here. And it's been really a very thrilling, journey and a lot of learning. And fortunately, my colleagues have done a lot of groundwork. I've been here not too long to be able to generate a good amount of data, but they've done a lot of studies before, and this is what I'm going to be referring to, and also the experience that I've had here compared to the experience that I've had in the previous work. At Baylor, I was both on the private and a quaternary center and also on the county hospital side. So I got to see a lot of endocarditis and a few merantic, but mainly a typical bacterial endocarditis. The patient were pretty sick and a lot of referred for surgery. And then now I have I've seen a fair amount of endocarditis here at MD Anderson. And interestingly, without, taking I've seen a lot more merantic here than I thought I will. So.
Well, great. Welcome. We really appreciate you being with us today and sharing that experience more thoroughly. Arjun, what's your experience in this area? What questions do you have for Dr. Hamzeh?
Yeah, thanks, Steve. So I think it's a very interesting area because we know that with cancer patients and treatment and immunocompromise, any types of infections may present differently in the cancer patients and the cardio-oncology patients. I think this will be quite a fascinating discussion. And I think Dr. Hamzeh has already maybe mentioned it, talking about merantic endocarditis and bacterial endocarditis. So I think my first question would really be, what are the different types of endocarditis that we see in the cancer patients, and what is it? How is it different to the other patients in your experience?
So thank you for this question. So essentially, what are the different types of endocarditis that we see in cancer patients, and how they differ from other patients? I think I'll start with quoting a study by my colleagues, Dr. Youssef and Hassan and Grable, from 2021. They did a very nice retrospective review of about 8 years worth of clinical patients that were suspected for endocarditis at MD Anderson. And what they found is about 56 patients that were using the Duke criteria, the modified Duke criteria, that had endocarditis. The interesting part is, like outside of the cancer population, the most common organism was Staph aureus. And this is the same thing that's happening outside. It was about 30% for our patients to have Staph aureus, followed by Enterococcus species, and Streptococcus viridans was about 12.5%. And the staggering finding was that it was culture negatives in about 30%. And I think we can talk about the culture negative endocarditis in a little bit more detail in a little bit. The worst outcomes were obviously in the Staph aureus population, and they had a hazard ratio for death of about 2.5. And the mortality was at 1 year for the patient with cancer and Staph aureus endocarditis was 80%, which is pretty high. And the rest of the patient who did not have Staph aureus about 40%. I think one of the issues is Staph aureus, which is also outside of the cancer patient, about 30% or more are due to Staph aureus, and it's the most common organism now. It presents an acute situation. It's frequently a surgical disease, which is 50%, and of all comers. It causes perivalvular abscesses, destruction of the valve, pseudo aneurysm, what have you, and frequently heart failure, and the patients end up requiring surgery during the hospitalization. Unfortunately, our patients, as you guys know, are not the picture perfect candidates for surgery for multiple reasons. They may have thrombocytopenia, they're immunocompromised, they may have had radiation, and some of them also may have pretty poor prognosis from their cancer treatment, or they may not be in a good functional status. So in the study by Yusuf et al., they found that only 12% were sent for surgery. And most of these were Staph aureus patients, essentially, compared to the in other population, about 50%. Now, there is another study by Cosenz from Europe that was about cancer patients, and they had a higher referral rate for surgery. Like almost 40% were referred for surgery among cancer patients. I think the important distinction between the study done at MD Anderson and that other study is, in the study done here, about 67% of these patients were getting active chemotherapy, while in the study by Cosenz, a much lower percentage, like 10-15%. So the majority of that study were patients who've had history of cancer rather than active cancer. So that makes a huge difference in a patient with a history of cancer 2 or 3 years ago, maybe recovered, versus somebody who's getting active chemotherapy or radiation and so forth. So I think these are the important distinctions. And the mortality was higher in our particular population.
Great, thanks. I think that's a really fantastic overview, and you've really raised lots of points that I'm sure we'll get into in more detail with the questions. I suppose one of the other questions that I'd like to ask before we get into the depth of it is, you did mention the due criteria for diagnosis. I mean, when you are diagnosing the endocarditis patients, the cancer patients who develop endocarditis, are there any other criteria, or do we need to look at the due criteria in a different way? Do we need to, is there some kind of modifications we need to do for taking into account the cancer status of these patients?
It's a great question. We do not use any other criteria. We use mainly due criteria for the diagnosis, using 2 major or 1 major and 3 minor. I will add that in 2023, there's a the due criteria were addended, and they've added the FDG PET for diagnosis, which is pretty accurate, both specificity and sensitivity, particularly with prosthetic heart valves. And whenever you have cardiac indwelling devices like pacemakers or defibrillators, and also CT were added as a major criteria. So a lot of times we have to, we kind of resort to FDG PET when the diagnosis is not certain by echo or TEE here at MD Anderson, but we still use the same criteria. I think the only difference is we have a lower threshold for aggressively testing them, whether with transesophageal echo, despite some of the limitation that can be like, for example, thrombocytopenia. Our group actually here have published a pretty nice study showing that with platelet counts less than 50,000, that transesophageal echo is actually pretty safe. and with a very small incidence of minor bleeding and no major complications. So before joining here 2 years ago, if a patient had a platelet of 49, we would wait until it goes up above 50 or transfuse them. Here, I think the average platelet count that I do is about 20, 17, give and take. So it was a major paradigm shift. But we tend to, within the DO criteria, we tend to be aggressive about testing these patients.
Yeah, that's very interesting, because even when we had one of your colleagues, Dr. Iliescu, on one of the previous podcasts, one of the points that he made was that the absolute platelet counts are very different, maybe the way they're judged at MD Anderson, maybe compared to a number of places, and the aggressiveness with which you investigate and intervene, I think, is quite high. So that's a similar theme. And I think my last question, I think, before I hand over to Dr. Lenihan, would be, in terms of the FDG PET, that's a very useful kind of test in our experience, especially the ones where there is any diagnostic uncertainty. And I know you mentioned that it's kind of come into the recent updated guidelines. Is that something that you would recommend that is more broadly used elsewhere, and rather than waiting, because often they do a TOE, it may be inconclusive, they wait for a culture, they wait for another culture. I mean, we're quite aggressive to try and get in the PET early. I mean, is that your recommendation, or what would you say?
I think we think we should use FDG PET as we use it in other patients, but maybe a little lower threshold. So if we have any uncertainty in the diagnosis based on echo or TEE, I think we should resort to FDG PET, particularly when there are indwelling catheter pacemaker wires, because as you probably guys have experienced, is you go in, you do a TEE, you may or may not see all the extent of the wire, or you may see a little thread hanging, and you don't know if this is fibrin strand, small clot that is innocent or is infected. So in these particular patients, I think my threshold is pretty low for FDG PET. Otherwise, I think we use it when we are not sure about the diagnosis.
Great. I think that's very interesting. I think those were really nice kind of answers for the audience, I think, just to get a very good idea of, the diagnostic strategies and what we should expect in cancer patients. But maybe I'll hand over to Dr. Lenihan for his thoughts.
Thanks, Arjun. My main thought is that this is always a super complex question if you're contemplating endocarditis in any patient, but it's especially complex in a patient who's being treated for cancer, whether it's previously or currently. But, just to add a little bit more spice to this whole conversation, not that we didn't have enough already, but when we look at the heart failure population, so that could be somebody who has cancer and had heart failure as a complication, or just patients with heart failure on their own without any cancer history, there's a high percentage of patients that have an indwelling device. And then if they present with some ICU level issue, so that they're placed in the ICU, and then somebody does a procedure, puts an indwelling catheter, then we recently published a paper just showing that the idea of putting an indwelling catheter in somebody with an existing pacemaker defibrillator is the single highest risk for the development of endocarditis. And whether or not you find a culture is a question. But then if you get a certain organism, for example, if you get MRSA, then you have to extract the device, regardless of whether there's any obvious endocarditis on there or not. So this is a really complex topic when you start talking about people that have existing devices, and then they have an indwelling catheter, and a patient with cancer is very likely to have some sort of port in place for their treatments. How do you guys deal with all of these issues in general?
It's a quite complex question, and it's usually a very difficult situation to deal with, and we individualize the care in that situation. I think you mentioned something very important that a lot of these patients have indwelling catheters and usually ports or PICC lines, and which are unfortunately a risk for bloodstream bacteremia, and which can seed the valves. I think one of the things they do at this institution, I think at most cancer institutions, is they are very good about the hygiene and the sterility of accessing these ports. So when patients are getting those as an outpatient for chemotherapy, we have not seen a lot of bacteremia because most often we get consulted for a TEE or something on these patients. So we don't see a lot of bacteremia from lines, even though some of the lines may end up being there for like a year or longer. We've seen a fair amount of clots form on the lines, but not that much bacteremia. But in the ICU setting, when somebody's sick and they slip in a PICC line or a central line, and then patients get febrile, and there's multitude of reasons for it, like whether it's pneumonia, et cetera. What we do is, if the cultures are positive and it's a typical organism or even a gram-negative organism, we end up, particularly if the culture remain positive, persistent, we end up imaging those patients, at least transthoracic, and if they have an indwelling device, we do transesophageal. So it's not a lot of fun to go and do the TEs in the ICU, but we've had to do some of those here and there.
Yeah, and I think that, as people go through the trajectory of their treatment, just things get more and more complicated. So existing lines, you took one out, you put one back in. If you have an indwelling device like a pacemaker or defibrillator, ideally, you don't want to do anything to that. And so, these situations, as you said, have to be very individualized, but it does show you that the complexity of these decisions is never just straightforward. I'm going to do a PET scan and it's going to be positive or negative, and that'll be the end of the road. No, it's another important step along the path, but the path it's quite long. And I think, it's a very challenging condition, and ideally preventing it is by far and away the best strategy.
Absolutely. And to add to your point, I've noticed that a lot of the patients that we get echoes on who are being either newly diagnosed cancer or being treated with cancer have TAVRs. And I think that's what I'm really worried about, because TAVRs have an inherent risk of getting endocarditis. And some of these patients probably would not have survived without the TAVR, would not have been candidate for surgical AVR. So I'm really starting to worry as we see more and more of these patients who are elderly with pretty bad cancers come in, that's going to be the next front of endocarditis on these TAVR valves. And that's going to be a really tricky thing to deal with. So I hope that doesn't realize itself, but it's a worrisome thing for me.
Well, and I mean, that's a great point. And I would say that is certainly a concern in those patients. But, when you're dealing with people, with chronic heart failure that have pacemakers and defibrillators, and they're essential for their survival and well-being, you certainly don't want one of those devices to get infected, and because if you do, then it's certainly a real super challenge, and the mortality from extraction and reimplantation, et cetera, is quite high. So it's tough. So let's change gears a little bit, and I would imagine at MD Anderson this is fairly relevant, which is the idea of merantic endocarditis. So could you just explain to the audience exactly what you mean by merantic endocarditis?
Yes, absolutely. As I mentioned earlier, in the study that was done at MD Anderson, out of all the endocarditis that were diagnosed, 55 patients, 30% were cultural negative. So I'm going to start by a segue in talking a little bit about culture negative, and then delving into the merantic endocarditis. So culture negative endocarditis occurs in about 10% of the patients. There's multiple reasons for them. One of them is the patient has already received antibiotics when the culture were drawn, which brings to importance that it's always important to get at least 2 blood cultures, at least 1 hour apart, if not longer, from a patient with suspected fever or endocarditis. The other one is when they have like difficult to grow bacteria, what they call fastidious bacteria, Hay-Sac, abiotrophia, etc. And the third cause of culture negative endocarditis is bacteria that you cannot grow, like Coxiella burnetii or Whipple's disease or Bartonella, where you have to do either PCR or antibodies. Now, taking these aside, then there's an entity called non-bacterial thrombotic endocarditis. And merantic endocarditis is mainly when we see that condition in patients who have cancer. Now, the same condition, very similar appearance and presentation, can be, if somebody has systemic lupus erythematosus, SLE, it will be called Lehmann-Sachs. And if they have positive antibody for anticardiolipin or antiphospholipid, it's called antiphospholipid antibody syndrome. They tend to look the same on echo, give and take, and manifest. The treatment is the same, but the etiology is totally different. So merantic is essentially a thrombotic type endocarditis, sterile endocarditis that we see mainly in patients with advanced cancer, particularly in cancers that are adenocarcinomas, lung adenocarcinoma, pancreatic adenocarcinoma, or GI source adenocarcinoma, and mostly in patients who have mucin secreting tumors. The pathology, and I'm quoting Ilchami from Oncology in 2007, is the way they describe on pathology is these are thrombi interwoven with strands of fibrin, immune complexes, and mononuclear cells. Because it's kind of the clot is adherent to the valve surface without too much inflammation, this makes it very easy to dislodge. So unlike regular infective endocarditis, where there's a lot of inflammation, even though those vegetations are very highly mobile, but they have an attachment fostered by inflammation on the valve. On the other hand, with thrombotic or merantic endocarditis, those clots just form, they're kind of stuck on. So any little movement, or if they grow enough, they can dislodge. So it's not a big surprise that a lot of these patients actually present not with fever, but rather with systemic embolization, typically like stroke. 50% of them will have embolization. And some of them can embolize to the coronaries, causing coronary events, as was found in one study by MD Anderson a few years ago by Dr. Youssef as well. Whenever you have valve pathology, it becomes another potential milieu for even superimposed bacterial infection, endocarditis. So anytime we see these patients with these vegetations, first we rule out endocarditis by doing cultures. In certain cases, we have to do a FDG PET. It was found that none of the patients with merantic endocarditis in one series have any positive FDG PET. And the appearance, which I think you guys are familiar with, typically it's a flat layer of thrombus that is on the valve surface. And with frequently on the leaflet tips, there's like kissing lesions, like, for example, mitral valve, the anterior leaflet tip and the posterior leaflet tip, wherever they coapt, there's like a nodularity there of extra thrombus. On the aortic valve, it's usually on the underside of the cusp, but mainly where the cusp touch and coapt as well. Now, having said that, we've seen here some cases where the vegetation looks so big, like I would swear that this is a bacterial endocarditis, and sure enough, they're sterile, they don't have any fever, and we treat them with anticoagulation and they get better. So this is and if I may add one more important thing is regarding the management of these patients. Essentially, these patients with merantic endocarditis, we've seen a lot of failure from direct oral anticoagulants. They don't work as well for these patients. So either they present with recurrent embolization while on DOACs, or the vegetation, the merantic endocarditis vegetation grows while on DOACs, and we found that the best treatment remains Lovenox or heparinoid treatment. And the other thing that is important for their treatment is essentially treating the underlying cancer. If the underlying cancer is very aggressive and it's not controlled, it's gonna eventually win that fight, unfortunately.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Yeah, I think this is what you just said a minute ago would certainly be a controversial point or one that could stimulate lots of discussion, but maybe it's not controversial. It's just opinion based.
Yes.
But certainly the treatment of morantic endocarditis is a real question. So I remember a recent case, probably within the last 6 months or so, where a patient had lung cancer and was being treated for that with combination chemo and radiation, and developed a stroke. This patient had a port, but on the echo had obvious vegetation on the mitral valve, and on the CT and MRI of her brain had more than one location of a stroke. And so she was initially placed on heparin, then transitioned to Lovenox. And a few weeks later, her mental status got worse, and repeat CT and MRI showed some possible extension or additional thrombotic complications. And because the patient was on therapeutic Lovenox at the time, I was like, well, we got to do something different. Obviously, it didn't work here. And switched her to Eliquis. And I actually also gave her aspirin in addition.
Okay.
And, after a period of time, her symptoms improved, and then repeat echo months later was there was no evidence of thrombotic process on the mitral valve. Now that's just one case, but this is where these situations are so difficult, because how do you decide what to do, or how do you manage those patients? Every decision is individualized.
I think that's an excellent point. And you're right. There's the jury's still out on this. And I think we need more data to decide what's the best treatment. But there's been several case reports published about, patients progressing or failing on DOACs. And this has been our experience here, that they tend to do worse on DOACs or progress on them. But obviously, I don't think every patient is the same. And I think at the end of the day, if their cancer is very uncontrolled or very widespread and there's no active treatment, then that process is going to continue to hypercoagulate. They're going to have DVT, PEs, they're going to clog the IVC filter, and those vegetation is going to grow. So I think it's a two-pronged approach. And as you said, the jury is still out about what's the best one, what's the best treatment. But this was my caution about DOACs in these patients.
I mean, you're obviously basing that on your experience, which is good, and I think that's all we can do. I would just say that an individual center's experience, could be fairly different from somebody else's, but that's also why in that situation I added aspirin to the equation, just to kind of have a dual anti-thrombotic type of process going on there. So, but yeah, I mean, This is it's not like this is a study. This is a patient experience and the decisions that you have to make. So
I had a patient just to kind of illustrate this, highlight it, is she had didn't have cancer. She had thrombocytopenia from a different reason, and she had antiphospholipid antibody syndrome. And we gave her Lovenox, and she clotted her original valve. Then we replaced it. Her bioprosthetic got clotted with the antiphospholipid. Gave Lovenox, nothing happened. And I'm now contemplating what the heck am I going to do? Like another redo or on X valve, etc. And they said, like, you know what? Antiphospholipid antibody requires Coumadin. And then we put her on warfarin therapeutic, and lo and behold, 6 weeks, her valve is the bioprosthetic gradient went down, everything looked fine, and the patient had no more heart failure, etc. So I think each patient is different, and the only concern with the DOACs is when we dose them, it's more of a maintenance dose, like the usual starting for DVT or thrombus treatment is 50% higher dose of DOACs in the beginning. So I don't know if that's the reason that we may be seeing failures or not, but I think the jury is still out, and it's be interesting to do some studies on this.
yeah, well, just to say that there was a state-of-the-art review in JACC just recently, within the last couple of weeks, talking about when DOACs should not be standard treatment. So that's a timely state-of-the-art review relative to your question. But I mean, this is really interesting. It's really a challenging situation. And what do you think? What is your basic monitoring strategy in these patients? So if you get endocarditis, whether it be infective or non-bacterial, do you have some sort of general interval that you do monitoring, or is it just a decision you make?
I think for the infective endocarditis, if the patient is stable with infective endocarditis, we do the same monitoring that we do in non-cancer patients. This has been our practice. Essentially, at the end of the treatment, if the patient is okay, not requiring surgery, we repeat an echo, usually transthoracic. And then depending on the degree of regurgitation that the patient may have endured from the endocarditis, then we will time the subsequent echoes accordingly. Now, not for the merantic endocarditis, just because of what we just discussed about the uncertainties, what's the best treatment, what's the best management, etc., we tend to do echoes like almost every 4 weeks on these patients. And I may not have mentioned earlier, usually it doesn't cause a lot of destruction of the valve, but when the merantic endocarditis is large in size, it causes problem with the coaptation of the valve. So you most frequently see some degree of regurgitation. It's usually not horrible, but sometimes can be severe, and less frequently some degree of stenosis. So in these patients, there's no hard data on it, but just because of the uncertainty and also because of their underlying process that is pretty aggressive with the cancer, we tend to do like every 4 weeks of a transthoracic echo afterwards, just to make sure the valves function okay. And most importantly, though, besides the monitoring, is making the diagnosis early. So I used to say that, a lot of merantic, you see it on transthoracic. You see those kissing lesions and the vegetations on transthoracic. But I've had a couple of patients where I looked at the echo and I thought the echo looked great as far as the quality. But they came in, they've had DVTs, they've had CVA, stroke, and they have the right cancer, pancreatic cancer, and so forth. And we do a TEE, and and it's amazing that you see all those thrombotic lesions on the valve that you do not see on a good quality transthoracic. So my suggestion is, if you have somebody with the right protoplasm for merantic endocarditis who's presenting with a TIA or stroke, if you don't see anything on the transthoracic, have a low threshold for TEE. They can start pretty thin, the thrombotic lesions, and they are better seen on the higher resolution TEE, even with good images transthoracically. I've been burned, so I just want to kind of share that experience.
Yeah, well, and I'd also add that in somebody who you who you don't feel there's infective endocarditis, and you do a TEE, for example, and you see some abnormalities near the underside of the aortic valve, and patient presented with a stroke or TIA, then you have to consider whether that's a papillary fibroelastoma. So just in these patients, just like you're saying, basically you need to have a wide view of what's happening and keep all possibilities open to you. So
yeah, speaking of the fibroelastoma, the other day I had a patient who it looked on transthoracic to be fibroelastoma on the aortic valve. We do the first picture on the long axis view of the aortic valve, and then you can see like it's almost like a stalk, and that little echogenic density is flip-flopping. And then I go short axis and biplane on it, and then you see that all cusps are studded with vegetations and thrombus. So I went from, oh, this is definitely a fibroelastoma, to, oh God, this is another Morantic endocarditis. So it's a very interesting thing. And that's why I'm like, I became really more proponent of getting TEs in these patients, because it makes a difference as far as treatment and what have you.
Certainly. All right, Arjun, what do you think about all these things?
Yeah, I think just a very interesting discussion on how we have to maybe individualize the care for a lot of the patients, because maybe the data isn't there and there may be differing opinions in the group. So what we do at Bart's Heart Center is we have the endocarditis MDT, where all the active patients are discussed every week. So we have the surgeons, we have the microbiologists, we have the infectious disease specialists, along with the oncologist and the cardiologist together, and along nuclear medicine specialists, everyone. So it can be an individualized approach. And I think especially, we talked about the challenges of anticoagulation in some of these patients, and cancer patients, of course, may have the baseline thrombocytopenia and all of these things. So it can be extremely, extremely difficult. And I think, as mentioned by Dr. Hamzeh, more data, more publications, and I think here, obviously, it's not trials, it's more about the experiences in large volume centers would be a guide forwards.
Well, thank you so much, Dr. Hamzeh, for joining us today. Thanks for sharing your experience with us in these complicated matters, as they seem to be every time we jump on one of these podcasts. We really appreciate your time, and we hope that we'll be able to speak with you again in the near future. Thanks. For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.